So without further ado, I am really honored to introduce Dr. Art Beaudette. You can read his bio, and I think that we all know him, and it goes without saying who he is and what he does. But the one thing I do want all of you to realize is that the first person I met when we got our diagnosis of Angelman syndrome was Dr. Beaudette. And that's because I was a desperate mother of a 7-month-old little girl, emailing every scientist that had any inclination of the word therapeutic that was related to Angelman syndrome. And he was the first person that wrote me back. And within 4 days, my husband and I were able to have a conversation with him on the phone. Now, I'm not going to give you his cell phone number because that would be inappropriate. But what I would tell you is he is one of the most world-renowned experts in Angelman syndrome. He developed so much research and really laid the groundwork for therapeutics, particularly in the area of paternal activation. He has trained or has touched almost every scientist in this room that is working on Angelman syndrome, and we all have him to thank for that. And aside from that, he's actually one of the most approachable and kindest people, and he really cares about our kids, and that's really hard to find with someone of his stature. So I welcome him with open arms to give us a talk about what genotype means and how that matters, and I'm glad to see he says a little bit, for those of us who have kids with a deletion.
Yes, someone gave me the title Genotype Matters, probably Allison, I don't know. And I added a little bit because I don't want people to, I think the kinds of therapies that are being discussed really can help all Angelman patients very dramatically, but there will be some subtle differences. Let's see. Oops. So I think it's kind of fortunate for this audience that I think that dramatic treatment, and I sort of was trained not to use the word cure in a situation like this because we might raise false hopes on the part of families, but I think in this context you'll hear the word cure again and again today and tomorrow evening particularly. But there are many genetic neurological disorders which are not likely to be curable in any time we can foresee at this point. I think that you could talk about CRISPR correction of embryos prior to implantation, but I don't think this makes sense. There was CRISPR in the media this few days ago, and there are families, maybe some in this room, who are at a 50-50 chance of having a child with Angelman, another child with Angelman, if they have another pregnancy. And I think the most attractive option for these families is to use what we call prenatal genetic testing. It used to be called PGD, now it's called PGT. That is, you would do in vitro fertilization, and you would expect that half of the embryos would be affected and would be expected to develop Angelman syndrome, but you could easily tell which are which with today's technology and only implant unaffected embryos. So I don't see us going and curing fertilized eggs that have Angelman syndrome because there would always be normal eggs available at the same time. But this is just one of what could be 1,000 examples of much more challenging and unfortunate situations. This is a condition called lissencephaly, which means smooth brain. And you can see on the left that there's a 34-week normal infant brain with, you can see some folds developing on the surface with the white arrows. And then in the next image, there's a 32-week gestation with lissencephaly. And these problems are evident even at 20 weeks gestation, and I don't see any way to talk about cures for a number of these disorders. And there's probably far more genetic neurologic disorders for which a cure is not a reasonable expectation. And fortunately for all of you, Angelman falls into a different category where there's, I think, reasonable room for optimism. So you can be thankful that you have some upside to the situation. Some of the things that are positive is that there's a relatively normal neurologic exam at birth, but those of you who've tried to breastfeed newborns with Angelman syndrome probably know that there can also be abnormalities in feeding and other things. But if you ask a pediatrician to do an exam on a baby born with Angelman syndrome, they'll say that the exam is normal. If you do an MRI of the brain or some kind of imaging of the brain, you can see that the brain looks to be normally formed. If you do an MRI, probably come back with a normal result. And from what we know of looking under the microscope at the brain of mice with Angelman syndrome, it seems like the brain looks like it's well formed and reasonably properly connected. We heard actually yesterday about the possibility of some small changes in the brain early on in rats, and so I don't really know, but if there's any reason for concern there. Next thing I'd like to emphasize is being a geneticist. I sort of have spend my life trying to figure out which gene it is or what mutation it is. And if you're going to treat, or particularly if you want to think in terms of cure various kinds of genetic diseases, I think you should think about fixing the gene problem and not downstream problems. So this is to sort of indicate that the UBE3A gene and protein probably have many, many roles in the brain, as many things are disturbed. And this image tries to show that if you correct the gene or the gene product, if you do it by a number of ways which have been discussed already today, you really hope to fix everything. Now, you may be later than you wish, and maybe there'll be some things that have happened that you can't go back and correct, but you really can expect to fix the thing and put matters back entirely right. Whereas downstream therapies usually look at some bit of the phenotype, some bit of the biology and the functionality, and try to affect that. There's another thing that maybe a lot of our understanding is seriously wrong. I think that there are some publications in press that will be out before too much longer, which will change a lot of thinking about what's really going on in the Angelman brain. And so if you go to downstream treatments, you might think you understand what's going on when you really don't. Whereas if you go to fixing the core of the problem, even if you don't understand how the brain is working, if you can put it back right without knowing how it's happening. So there are a lot of various forms of gene product normalization is what I'm calling it here. You can do protein replacement therapy in disorders like hemophilia. You heard that there's more, and you'll hear more about gene therapy progress. There are various kinds of RNA and ASO knockdowns and activations and so on. And of course, CRISPR nowadays is certainly at the top of the list of ways to go in and change genes. So before we could start thinking about fixing the gene, we have to know which one it is. We were very fortunate to be involved in recognizing the answer to this question, although we actually should have done it sooner, given on some of the data we were sitting on. But in 1997, our lab and another lab realized that mutations in UBE3A cause Angelman syndrome. And shortly after that, there was a publication by Mark Lalonde's group indicating that there was an antisense RNA that was made, and it was it says imprinted antisense RNA, meaning it was made only from the father's chromosome. So the father's chromosome was inactive, but it had the antisense. The mother's chromosome was active, and it didn't have the antisense. So we were envisioning this kind of diagram here. Let's see if I can. Oops. So what you can see here is at the bottom is the attempt to demonstrate the maternal chromosome with the UBE3A gene in red, and the sense transcript here I'm pointing to. And then these little steam engines going down here producing the Angelman protein, which is the red blocks. But we now know that on the father's chromosome, the gene actually starts being made, and the first front end of the gene is synthesized, but then it hits the antisense in a collision mechanism so that you don't get any product made from the paternal chromosome. Now, the gene activation strategies in general want to somehow allow the father's copy of the gene to now be completed and to make protein. There is one key assumption here that would be very favorable. I think all the data suggest it is likely to be the case, and that is that if you turn the father's copy of the gene on, it will behave exactly like the mother's would. The reason we think that's true is that all of the starting machinery for making RNA is intact and appears to be identical on the father's chromosome as it is on the mother's chromosome. So there are a couple of people here, Terry Jo Bichel for one, who were at a meeting in Finland in 2000, where this was shortly after we had identified the gene, and I got into some email exchanges with Dr. Huda Zogby, who was looking at Rett syndrome, and they were talking about the possibility that folic acid maybe could be used to make some changes in Rett syndrome that are not important for us, but we thought that maybe there was a way that you could activate the father's copy of the gene even back in 2000. Part of the reason we thought that was that we had done some studying of UBE3A in brain, and I'll just go, you see at the very top center here, there's this thing called tissue-specific differentially methylated region lying between UBE3A and the origin of the antisense. And when we looked at this, you can see here that in cerebellum, where the imprinting is on, this region is unmethylated here, thinking that the this would affect the copying of the antisense. And then in these other tissues where both copies of the gene are on, this region is methylated. So we thought if we could make the brain more liver-like by folic acid, which might promote methylation, this might turn on the father's copy of the gene. So we've been thinking along these lines for a long time. And actually, I convinced a number of colleagues to look at this in patients, and there's a couple of publications out there. This was one that appeared considerably later, although the work had been done long before the publication appeared. And we conducted a trial using methylation-promoting dietary supplements like betaine, metformin, creatine, and vitamin B12 in an attempt to reduce antisense transcript production and increase UBE3A expression and ameliorate the symptoms of AS. So we were playing around with that kind of idea back quite a long time ago. I can't emphasize enough how fortuitous this situation is for Angelman syndrome to be able to pursue this strategy of activating the father's copy of the gene. there's very few genes in the genome that are subject to genomic imprinting that leaves an extra copy sort of lying there ready to go as an alternative. I think the fact that we can use ASOs now that by virtue of their sequence can be targeted to a particular gene or region and particular part of a gene. And it's also possible to activate the antisense portion without to block the antisense portion without causing other problems that might cause Prader-Willi. And then there's very encouraging ASO results in spinal muscular atrophy, which we heard, and I'll show you one more slide about that. The ASOs distribute well in the brain, as you've also heard, and hopefully, as I've said, the paternal copy would be behave as if it was the same as a maternal copy. I think that Spinraza is a drug that is now on the market for treating spinal muscular atrophy, and this slide just depicts that. It's being used to treat infants, it's being used to treat teenagers, and it's being used to treat adults. And this is a good precedent for where there is a drug that can be beneficial at a later time in life. And I think one of the big questions is what will be the optimal time to treat, and if you are treating later than that, what will be the benefits? But I think I would endorse what Allison had to say about we just have to wait and see. I think that I don't think there's much precedent at all that one should really make a guess. So there are all these forms of Angelman, which you've already seen from others today. I just want to make a point that the deletion form is de novo. That is, that neither parent has the deletion, and it's a new event, and the recurrence risk is very low. The uniparental disomy is also a de novo event. Neither parent has an underlying abnormality, and you end up with 2 paternal copies of the chromosome 15. The imprinting defects, they can be de novo or they can be inherited. There are some large families where there are multiple members affected with imprinting defects, but more often they're de novo. And so if they're de novo, their recurrence risk is low. If they're inherited, their recurrence risk is high, as 50% usually. Then there are, so this is set up with a separation of the imprinting with a deletion in the imprinting center and without a deletion. So the ones without a deletion are uniformly de novo, and these can be associated with in vitro fertilization. It's a very low risk, but there is an increased risk of causing Angelman syndrome by virtue of in vitro fertilization. It doesn't get a lot of discussion because it's so rare. And then there are the point mutations in the Angelman gene, which is what allowed us to identify the gene in the first place, and these can be inherited or de novo. And if the mother carries the mutation, then there's a 50-50 chance that each child born will be born with Angelman. Now, for the group in the middle, the UPD and the 2 kinds of imprinting defects, there's 2 paternal copies of the gene, or 1 paternal copy and 1 paternal-like copy. It's really a maternal, but the region of the Angelman gene is behaving as if it's paternal. So if you're going to activate the paternal copy of the gene, it's relevant to know and think about whether there's 2 copies there to be activated or 1 copy there to be activated. The great majority of the patients have deletion, and they have only 1 paternal copy, and the UBE3A point mutations also have a deletion, also have only 1 copy. So there's actually quite a lot of complexity around all of these different forms as far as what the implications are for some kind of gene therapy or gene correction. So at the top, I've got a deletion class 1, which is the larger deletion. There's 1 copy of the paternal chromosome, And I'll show you in a bit that there's 11 other genes that are deleted and are decreased in their level of activity. For deletion 2, it's smaller, and there's only 7 genes that are also deleted and decreased in their expression. For UPD and imprinting defects, there's now overexpression of the genes that come only from the paternal chromosome, but we're not aware that this has much or any harmful effect. And in the UBE3A mutation, there's just one copy of the paternal chromosome, and everything else is normal, just only this one gene is involved. Now, things got a lot more exciting in 2011 when Ben Philpott's group described, as you've already heard, that topoisomerase inhibitors could activate the paternal copy of the gene in mice. Then a student in my lab showed also that if you introduce a stop signal in the region where the antisense is being made, that you can dramatically activate the paternal copy of the gene. And this was further, there was known that there was a correlation between antisense and the paternal allele being shut down, but this really showed it was a cause and effect, that if you stopped the antisense, you were able to turn it on. And this image I just show you that this shows the YFP or tagged copy of the Angelman protein being made in the stop mouse here, whereas the regular size is down here. And what it just shows an absolutely complete activation of the paternal copy of the gene. And to the extent that these bands look similar intensity, it suggests that the paternal copy is behaving just like a maternal copy. Then the same student in my lab went on during postdoctoral time to demonstrate that you could use ASOs to accomplish similar things to knock down antisense and increase antisense. Now, why antisense oligos? Well, they are nucleotides that can technically be DNA or RNA. They typically are around 20 bases long. They're chemically synthesized. And it allows you to direct where in the genome they will go by virtue of 20 bases is enough to say there's only going to be one or a few matches for that particular 20 bases. So you can target specific genes and regions. They're highly stable. There's good biodistribution, and they can be delivered to the spinal fluid as has been demonstrated particularly with Spinraza. So now I'm going to get into the weeds a bit here with the complexities. This is, I put this in here just to say that I stole this image from Stormy Chamberlain and a person in her lab as the best available display of all the different genes in the Prader-Willi Angelman region. And what I show you here is normal at the top. There's the paternal chromosome is on the top. It's got some blue genes which are expressed only from the paternal chromosome. The Angelman gene is in red here. And all these genes in gray are expressed from both copies of the chromosome. So a class 1 and a class 2 deletion are shown on this slide. And in the class 1 deletion, you see you have deletion all the way from here, all the way down to here. And that means that there's 4 genes here which now have only one active copy when they should have 2. These paternal genes are turned off on the maternal chromosome anyway, so maybe that's not so important. But you have another 7 genes down here which are deleted in both class 1 and class 2. They have some GABA receptors, which are genes that have a role in the brain and could be important. They also, this region also includes an albinism gene, and it's really the fact that patients with deletions have only one copy of this albinism gene rather than two. That makes them somewhat lighter skinned and lighter complexion than their family typically would be. And it's one good way to think about this is if we fix the Angelman gene, we wouldn't expect it's going to fix the pigmentation difference, because we won't be doing anything different with that gene. We're going to go in and just deal with the Angelman gene. And so this region right down here with the green, this is the part that isn't deleted in class 2 but is deleted in class 1. So something about genetic classification. Type 1 and type 2 deletions are really what we call contiguous gene syndromes. There's many genes involved, but the overwhelming bad player is the UBE3A gene. But there are other genes involved, and it is the deficiency of these other genes which explains why deletion patients may have somewhat more severe phenotype than the point mutation patients or than the imprinting patients. So the UPD and imprinting defects are multi-gene disorders. There's many genes affected, again, but by a different mechanism, not by deletion, but by altered imprinting. And then the UBE3A point mutations really are a single gene or Mendelian disorder. So we have the common issue, common abnormality is a deletion. There are many genes deleted, but the really key player in the region is UBE3A. So if we fix, have by some kind of a correction mechanism, and this is, I'm going to focus here on activating the paternal copy of the gene. You would come in here and activate the paternal copy. You would still have half normal levels of these gray genes here, so you would have a late start for treatment. Treatment or the gene availability should be from conception, but you're going to now provide it at some later time. You still have half normal level of 4 genes in one region and another 7 genes, including the albinism gene. And other kinds of things would be normal. So you might ask, well, why don't we just put in a big piece of DNA that will fix everything, put all the extra copies of the genes back in? And I would say that the technology is not there at this time, and it doesn't seem like it would be there soon. In a way, the ideal fix would be to go in and just put in what's missing, but that would be a very large piece of DNA. We don't have a way to manipulate that or deliver it at this time. Now, I'll go back a minute here. The 4 genes down here in this region, we do know something about patients who have a deletion of these 4 genes. That is, they have 1 copy of each of these 4 instead of 2. This is often referred to as the 15q11.2 microdeletion, or the breakpoint 1, breakpoint 2 deletion. Now, if you have a patient with a class 1 deletion and you fix the UBE3A circumstance, you're still going to be left with this deletion, which we sometimes see by itself. It's actually a pretty common deletion. The majority of the time, it's inherited from a parent who's normal. But there does seem to be some increased disabilities here. You see, talk about developmental delay, behavior issues, epilepsy, and congenital heart disease, which I'm not sure that's very convincing, because I don't know if any of you know about Angelman patients with congenital heart defects in addition. That would be interesting to know which deletion they have. So this is somewhat going to be a risk factor, and there could be some children who wouldn't be completely corrected because of this consideration. Actually, Allison brought this to my attention some time ago with concern about it. So this is a corrected class 2 deletion. Now you still have these 7 genes, which have only 1 active copy instead of 2. But otherwise, things are normal once you get the activation implemented. Then you have uniparental disomy and imprinting defects. Here you have, in UPD, 2 true paternal copies, and in The imprinting defect, you have an abnormality of this imprinting control center, which makes the maternal chromosome behave like it's paternal. So we have a paternal and a paternal-like chromosome. And if we correct this, again, the treatment gets started whenever it starts. You have potential to have twice the normal levels of UBE3A. And some people may raise this question, could this harm an imprinting defect patient? Should imprinting defect patients be among the first or among the last to get treatment? On the good side, if they have two paternal copies, they may be able to respond better to a partially effective therapy. So maybe on the one hand, you could say they may be the ones who will respond the best, but if you really activate both copies completely, maybe that will be problematic. Again, they will all have two active copies of the blue genes, but we don't know that that causes any harm. We don't know that it doesn't absolutely, but it doesn't seem to. And then the imprinting defect corrected is very similar. You have now the potential to activate two paternal copies and maybe get too much UBE3A. And then in the point mutations, here you have just a tiny defect in the UBE3A gene itself. If you correct that now, you still corrected it whatever time you were able to correct it. But otherwise, things have gone back to normal. There shouldn't be any other genes involved in abnormal. So to come back to a table I showed you earlier, you've got one paternal copy for deletions and point mutations. You've got two paternal copies for imprinting and UPD. As you undertake the therapies, one point would be that if you do gene therapy, the paternal copy number would no longer be relevant because you would deliver the same expression to the cell and we wouldn't be touching the paternal copy, it would just be sitting there. So the number of paternal copies is not a variable for gene therapy, but it is a variable for gene activation. And none of the methods would correct the expression of these other genes. So gene activation, I've raised a question, are UPD and imprinting defects the most favorable or the least favorable for treatment? Can a one-time permanent activation of the paternal gene be achieved? This will be a topic of the various discussions. For gene therapy, you typically use a cDNA, which means that you have to choose a particular isoform, and there's complexities there that are yet to be fully delineated. You could wonder, could we use the entire gene, which might help with the regulation and making the different isoforms, but that's not currently what would be the most obvious starting point, and Jim Wilson may talk about this. There is CRISPR. You could insert an antisense stop signal as a way to activate the paternal copy of the gene. You could use CRISPR via a gene therapy vector to do this or to do other kinds of things. And you could actually do gene correction for the UBE3A point mutation patients, but the CRISPR to correct the mutation wouldn't be relevant for the deletions and the imprinting defects. Finish with just a couple of slides. Universal prenatal diagnosis will be possible for Angelman syndrome for people who would elect to have an amnio or CVS today. With current technology, the deletion cases would easily be detected already, and it would be possible to improve matters. We've been working on a test that would allow you to do a non-invasive test that would detect most all of these kinds of disorders at about 8 weeks gestation using single fetal cells here. This is a fetal cell next to a couple of maternal white cells in her blood. And you could ask about, will prenatal treatment be possible for any of these disorders? If we can diagnose all the patients at 8 weeks gestation, would it be beneficial to start therapy 4 weeks before delivery versus immediately after delivery? So I think this raises complexities for, is my child going to be more or less benefited? And I'll be happy to try to take any questions, but I'll stop at this point.
We have time for a couple questions, and otherwise we can also answer a lot of these in the roundtable because Dr. Beaudet will be part of the roundtable discussion. Any questions?
I have one over here. Art, thank you for that. That was a great explanation. Regarding the genes that are also deleted in addition to UBE3A, is there any basic science work done to see whether those gene products are actually decreased in individuals? Do we know whether there might be other forms of upregulation in individuals who are deleted off of the paternal chromosome?
They've not been looked at exactly in that way, although I think that everybody would assume that if you checked at an mRNA level or at a protein level, there would be half normal levels. That's believed to be true for the pigmentation gene, and it's assumed to be true for the others, but I don't know that anybody's really looked carefully to confirm that.
I actually have two questions over here, Allison. I actually have two questions. One is I find it incredibly interesting that some children with deletions, large deletions, are not pale with blue eyes and may have dark hair with brown eyes. And I find that incredibly interesting, and I'm curious what you think that means. And the other question is that could you comment on the fact that there are some individuals that have been identified that have defects in those other missing genes that you talked about, the other genes on the outside of the area, and they are asymptomatic or non-diagnosed with any type of major neurologic or impacted condition?
I'm not sure. So let me talk about part of it. I'm not sure I have
You do the brown hair first.
So I think that what happens is that there's variability in how active these pigmentation genes are and how, there are people dark-skinned, light-skinned, and so on. And if you've got two copies, if one is kind of on fairly strong and one is on fairly weak, when you take away the weak one, it doesn't affect the pigmentation very much. But if you take away the strong one, that will be more noticeable. So there's a lot of variability in the level of expression. So one would say, to the extent that you can't see any of that lighter color that you might expect, you could say that's non-penetrant in that case. The other thing which you do see, I don't know how many of you know individuals, but we do see occasional patients who have a mutation in the pigmentation gene on the copy that isn't deleted, and they have albinism and Angelman, or sometimes Prader-Willi syndrome. We have a little bit of that kind of information. We don't have much good information about all the other genes other than the pigmentation gene. And then you were asking...
Kind of the same question. So may there be a penetrance of the other genes in that there are some humans that are diagnosed with deletions or mutations on those other genes and are asymptomatic?
I think just like the albinism, if you take the 4 genes that are down at the end there that are deleted in the class 1 and not the class 2, again, there's probably more and less active copies of these. And that's why you have probably the majority of the people who have a deletion of that region are healthy, normal, and they show up as parents of healthy parents of children who have a deletion but have some symptoms. So it's a lot like the albinism. You can relate to that if these 4 genes, and some of them are going to be more important in brain than others, but if they're kind of active enough, they cover for the missing one. If their expression is weak, then the missing one causes symptoms. And that's probably a fairly common explanation for penetrance and non-penetrance. And I think your point is about the pigmentation, that why do we see the hypopigmentation sometimes and not others? That's an example of penetrance and non-penetrance. And I think it's explained by what is probably the most common explanation.
Yeah.
Hi. Going back to the 4 and the 7, is there any connectivity between those specific genes and some of the symptoms that the Angelman syndrome children are afflicted with, whether it's the inability to walk or to speak or the seizures or the sleeping? Is there a connection between those, and do you understand which ones are affecting which symptoms?
So I think we say that the Angelman gene is the main player because if you have a whole group of Angelman patients and you show them to a clinician in the clinic, for the most part, they can't tell which ones have which kind of abnormality. That depends on laboratory testing. So we say if you just knock out the Angelman gene or you knock out all these genes, you get pretty much the same phenotype, but not entirely. Everyone will tell you that the patients with the largest deletions have the most difficulty with epilepsy and some of these other kinds of things, and the patients with the smaller deletion don't have as much trouble as the ones with the larger deletion, but they have more trouble than a point mutation or imprinting abnormality. So there's all these complex things going on. In the 7 genes that are clustered at one end, there are a series of GABA receptors. Those are known brain functional genes, and they're sometimes suggested to be playing a role, and I'm not really clear if the Ovid drug interacts with one of those genes or some other gene, actually.
Thank you. Okay, there'll be plenty of time for, do you have one more question? I see you looking at me begging for a question. You can give it if you want. I'm going to change over slides while you give that. One more question for you.
For the UPD or the imprinting, what is the plan? Are there animals that are being developed to test for the UPD imprinting to see if there would be an overexpression of the gene?
Actually, when we very first discovered that this was the gene and that there was something going on with imprinting, we were able to access mice that had been bred to have 2 copies of this region from the father or 2 copies of this region from the mother. They're kind of complicated to breed and obtain, but other people have made imprinting defects in mice. We have and others have. They aren't a big focus of research at the moment. It's kind of assumed that if you fix the UBE3A mutation, you'll fix the problem in the imprinting defects and UPD.
Thank you so much, Dr. Beaudet.